Okay, I'm going to pick up here with our guidelines for signs, symptoms, and integral conditions for coding. So signs are things that the doctor can validate, test results, things they can see. Symptoms are what the patient will experience that you really maybe not necessarily can see. So you can't see pain. You could see maybe issues that would cause pain. Maybe you could see some facial expressions that would indicate pain, but you can't see pain. So that would be a symptom. And then the signs and conditions are the things that you can see, things you can validate maybe with a test. And then integral conditions are going to be things that are inherently a part of something else. So we're going to look at the guidelines for coding for that. When you have an outpatient situation, again, we're concentrating on that, you cannot code for things that are not definitively diagnosed by the doctor. So if they say probable, suspected, rule out some condition, you cannot code this until they have said this is the diagnosis for sure. In that case, what we have to do is code the signs and symptoms that the patient comes in with. Now, inpatient coding has a different requirement. They can code these diagnoses, possibly, depending on the situation, as the condition, even if they're not definitively diagnosed. Okay? Now, on the other side of that, if you have a definitive diagnosis, this is what the patient has, but you also have in your documentation signs and symptoms, you don't code those signs and symptoms if they're an integral part of the condition. If they are not, typically something that would go along with the diagnostic condition, the diagnosis, then you do code those as secondary codes. Okay, and most of your signs and symptoms are going to fall in the R's. And we'll see more about those once we get into our individual chapters. Okay, so if you don't have a definitive diagnosis, the doctor said this is what it is. Now they could be wrong, that doesn't matter. The point is they have said this is the diagnosis. If they said suspected pneumonia, you can't code pneumonia. You have to code the signs and symptoms. But if they say pneumonia and then you don't also code signs and symptoms, I have included in your Moodle site a couple of links where you can go and research what are common signs and symptoms of a condition, so you would know whether you need to code these or not. And there are reference materials out there that you can purchase once you go to work, or your company will purchase for you, that will help you determine those things as well. This is a fairly smart little small flow chart, so you may want to look at your textbook to look at this. But this is determining whether you need to code for signs and symptoms, so you can walk through that to see whether you need to code for those in addition to a definitive diagnosis. All right, multiple coding for a single condition. Sometimes you need more than one code for one diagnosis. Okay, so your manual will guide you on that. They will use these instructional terms such as use additional code. So here's an example, the N3 9.0 urinary tract infection. Site not specified, so not a specific site in the urinary tract, but all we have is a urinary tract infection. Your coding manual tells you to use an additional code, and they give you codes to go and verify. Again, never code without verifying, to identify the infectious agent that is causing this infection. Okay, so it's telling you you need an additional code. Then it may use something like code first. So that tells you you need a primary code in front of this F48.2, the pseudo-bulbular effect. Okay, and it says code first the underlying cause, if known, such as, and they give you a list of conditions that could cause this situation, and those are coded first, and then your F4 8.2 would be coded secondary. And here's where I was mentioning the little dash after the code. That tells you that there's definitely additional digits required. But even like this one that doesn't say that, you still go to the G's and you verify this in the tabular. And then we have the instruction code, if applicable, any causal conditions first. So this tells you where that code goes. It goes in front of the MO2, okay, which is post-infective and reactive arthropathies. Okay, and then it gives you some codes to get started with. This doesn't mean this is the only underlying conditions, but these are given to you for ease of reference. But again, you do go and verify these. All right, acute and chronic conditions. Let me go back here for just a minute. I want to point out to you some terminology. If you're reading the notes, and I do encourage you to do that. So at the bottom of your, oops, that's not what I meant to do. Of your PowerPoint slides, there are notes. Okay, so I do encourage you to read those. All right, so for here, they mention the terms etiology and manifestations. Etiology is the cause of something, and the manifestation is the resulting issue. So for example, if somebody has diabetes, they often have retinopathy, problems with their eyes, or either nephropathy, problems with their kidneys. These are very common manifestations or results of having diabetes. Okay, so often things like this will require the two codes, an etiology and a manifestation. Okay. Another thing I would encourage you to do is to keep a list for yourself of terms that you run across that you're unfamiliar with. Acronyms, like if you don't know what the NCHS is, I would recommend that you write that down. And if you put those into a Word document, you can easily alphabetize them so that you can find these easily as you add to them. So you don't have to remember which chapter was. I saw that, but I know that I need to go back and look at it. Okay, so acute versus chronic. So chronic is a long-term kind of ongoing progressive condition. Acute would be usually a short-term, severe, or even an exacerbation. If you don't know what exacerbation is, that would be one of the terms you would add to your list of a chronic condition. So it's a worsening of that chronic condition. So for example, somebody may have asthma. It's a chronic condition. And then they could also have an acute attack. So if you have a chronic condition, you can code that chronic condition as many times as necessary. If you have an encounter that is documented both acute and chronic at the same encounter, and there are two separate codes for that. Sometimes there is one code that says acute or chronic, and it doesn't really matter. But if there are two different codes for, say, asthma, one is chronic, one is acute, you can code both of them if it's documented for that encounter. And you code your acute code first. Okay. So one of the guidelines for correct coding is, and this is a guideline, there are exceptions, of course, to the guidelines, so it's not always this is what happens, but in general, you code the reason that the patient is there today as your first listed diagnosis. Okay, so that means it goes first on your claim form. Doesn't necessarily mean it's first in your documentation. Okay, but when you're coding for the reimbursement, you're putting these codes on your claim form. That is the one that goes first listed diagnosis. Okay, so that would be acute when you have both acute and chronic, because if they're there today, they have the chronic condition, but they're going to be there because of the acute exacerbation or flare-up. Okay. right, so if you have both acute and chronic in the same encounter and they're two separate codes that are the same level in your manual, you're going to sequence your acute code first, followed by your chronic code. All right, next we're going to look at combination codes. So combination code is where there's one code that encompasses more than one thing. So you could have a situation where you have a code, one code, that includes two diagnoses. So for example, if you look up K57.91, this includes diverticulosis and bleeding. The diagnosis J85.1 is a combination code that includes a diagnosis with an associated result or manifestation we talked about a minute ago. So this is an abscess of the lung with the manifestation of pneumonia. So the etiology, the cause, the problem is the abscess of the lung, and pneumonia is what resulted, the manifestation. So that one code takes care of both of those. And then we could have something where we have a diagnosis with a associated complication. Now, if you're going to use these combination codes, you have to make sure both of these exist or are documented. And then we can have a diagnosis with an associated sign or a symptom. Now, just because there are two diagnoses or two things going on, it doesn't necessarily mean, excuse me, that they are, for example, a complication. And I've lost my... It doesn't necessarily mean it's a complication. That has to be documented as a complication of the original diagnosis by the documentation and the doctor. Okay, so the K57.21 is diverticulitis of the large intestine with perforation, so that means it has a hole in it, and abscess, which means a collection of pus, so some infection going on, with bleeding. So if you're going to use this code, remember we talked about the coding convention of and. When they use and, we read that as and or. So if your documentation had diverticulitis of the large intestine with perforation but not the abscess, you can still use that code because we read perforation and or abscess with bleeding. So if it had abscess but not perforation, you can use that code. But that has to be all documented by the provider. And so if we didn't have the signs or symptoms, we couldn't use this code. We'd have to use a different code. So everything has to be in there for us to use those combination codes. So combination codes are identified by referring to exclusion notes. So the tabular list, we always verify in our tabular list. Inclusion notes and subterms in the alphabetic index. So that can tell us where to go in the index, in the tabular, to verify this information. So all of these together will tell us whether or not we can use a combination code. All right, so our next topic is sequela. Okay, and this is the plural of sequela. It's pronounced sequelae or sequelae. Okay, so sequelae is a late effect, something that is ongoing right now because of something that happened in the past that is now resolved. So this is called a residual effect. Okay, an ongoing condition or problem, a current thing, because of something that has happened in the past that is now resolved. Okay, so for example, you may have somebody who had a fracture previously, a broken bone that has healed incorrectly. So we would call that a malunion. Okay, so if we have a malunion, the fracture has healed, so we do not have a fracture. So we can't code that the patient has a fracture, but we need to tell the whole story. So we're going to code the malunion